Hi, everybody. Today we're going to be discussing urinary calculi, okay? And going to be looking at this from a clinically high yield perspective and just make everything clinically simple, okay? So when it comes to the urinary calculi, the urinary stones, they're caused by an excess accumulation of substances, and they can get stuck here, and they can get stuck in the kidney, the ureter, or even the bladder. And in this case, they are stuck in the ureter. The stone is stuck in the ureter, okay? Just to give you a quick review of your anatomy, you have the kidneys, then you have the ureter, then you have the bladder, and then you have the urethra. So, what are the main ideas? What are the main investigations? What is the approach you need to have to the stone, depending on its size and type? Some of the stones you'll see when they're bigger, they require a more invasive kind of management or treatment. And some stones, when they are radio opaque, they can, some kind of methods of investigation, such as the X-rays, can be used as compared to the radiolucent. Now, we'll get into that and we'll discuss the treatment and we will discuss everything in a simple way. Now, if there are too many electrolytes, too many substances, such as calcium or phosphate, this accumulation of substances can lead to stone formation. What about our investigations? Now, as physicians, we need to know about our investigations. Your most appropriate one is your non-contrast CT scan. Okay, it might come as a surprise to you because a lot of people want to say ultrasound, but your initial investigation might be ultrasound. Yeah, it will be ultrasound. And the secondary investigation, second line, might be IV cytoscopy. But your most appropriate is, in fact, CT scan, okay, as according to the UK guidelines and for PLAB purposes as well. So, different types of stones that can form. You can form a calcium oxalate stone due to elevated levels of calcium in the body, okay? Now, you need to understand that it's not just calcium can be elevated due to a number of different reasons, dietary reasons, as well as hyperparathyroidism. And when calcium is high in hyperparathyroidism, this increases the chances of developing a calcium oxalate stone. Now, if that develops in the kidneys, that's known as nephrocalcinosis. Nephrocalcinosis. Now, what other things? Well, the most important thing as well to know is that it's not just calcium that's elevated in the serum. Calcium elevation in the serum doesn't actually increase the risk for the calcium ox stone. What increases the risk for the stone is when there's increased levels of calcium in the urine. Okay? You need to know it's radio opaque. That means that on X-ray, it will cast a shadow that, see, looks opaque, okay? And that's important because some of these are radiolucent, meaning that they won't be as visible or show up on the X-ray as a shadow. What about the struvite stone? Struvite stone is made up of magnesium, ammonium, and phosphate, and these commonly present due to recurrent UTIs. And the thing is, there is something called a Staghorn stone, and the management starts from there, and then we can start to assume what the management might be for a few other stones as well. So, Staghorn stone is basically when the struvite stone then gets stuck into the Staghorn stone is when it's fixed into the renal pelvis, and it actually displays 2 or 3 spikes that are fixed into the renal pelvis, and this is typically big. So typically this does in fact require some kind of surgery, okay? Surgery. Now, the approach depends on the size of your stone. So, by the way, before we go on, just to reiterate to you, a lot of stones do occur in our patients, typically female, typically older age, typically or maybe even obese, and they don't have enough fluids. They don't take enough fluids, right? But the stone might be small enough that it can just pass out just by fluids or over the period of time. So typically, these stones, these urinary calculi, self-resolve. That means that they pass out by themselves without needing physician intervention, okay? But when we do need intervention is when these stones are big, okay? If it's less than 5 millimeters, and you know 5 millimeters is very, very small, okay? When it's less than 5 millimeters, you would just advise the patient to increase their fluid intake, okay? They might say, Doctor, I'm concerned, but you need to advise them to increase their fluid intake. If the stone is more than 5 millimeters, so more than 5 millimeters, but up to 2 centimeters, now that's quite bigger, okay? That's 20 millimeters, okay? Not almost, it is 20 millimeters. And that means it's bigger. So now we're going to advise lithotripsy, where we're going to use these ultrasound, high frequency kind of waves to break down these shock waves, right? To break down and kind of deaggregate, just break down that stone, okay? Now, the most stones do pass by themselves. You need to understand that, and the approach really does depend on the size. If it's more than 2 centimeters, you are going to have a different approach. This is going to call for a percutaneous nephrolithotomy, okay? That means when you actually go through the skin and you do this kind of surgical intervention where you are then going to break down the stone. Okay? Now, what were we saying about struvite? So calcium oxalate stones occur in the presence of elevated levels of calcium. Struvite stones then occur when the patient has recurrent UTIs. So you need to be aware of this. Whenever the patient comes with recurrent UTIs, they are at increased risk for developing these struvite stones. Third stone, uric acid. This is when you have high uric acid, such as in gout, and this high uric acid can also be present when patients with cancer are undergoing chemotherapy and tumor lysis syndrome as well. Now, calcium oxalate and struvite, they have something in common. They are radio opaque. Once again, that means that they do cast a shadow on the X-ray. The cysteine stone and the uric acid stone. So cysteine stone forms with cystinuria. These two are radiolucent, okay? That means that these do not cast a shadow on the X-ray and they're not as visible. So, you want to recall the causes of each of these stones because that is high yield to understand, and then you can try and figure out with the patient diagnosis. So if they have recurrent UTIs, you want to be thinking about your struvite stone. If they have gout, you want to be thinking they have increased risk for a uric acid stone. If they have chemotherapy, you want to be thinking uric acid stone. Okay? What will the patient present to you with? Now, this is arguably the most important thing in your history as well, where you have to look at the patient's history as well as their clinical symptoms. And do you know why the history then becomes important? Because pain and hematuria are kind of vague, okay? Why is there even pain and hematuria in these stones, in these urinary stones? Well, there's pain and hematuria because when the stone, for example, is stuck in the ureter, that contact with the walls of the ureter stimulates the nerve endings, and that's going to cause excruciating pain for the patient, okay? And why might there be hematuria? There might be hematuria because the stone, as it's lodged in the ureter, it can then cause scratches to the walls, and that will then result in blood. Okay? Now, if you understand so far, it's good. Stay with me. If there is a stone in the bladder, this commonly presents with, it's not flank pain, it's suprapubic pain. Flank pain is more so for the, not just it's kind of like for the renal pelvis pain. And remember, bladder, suprapubic pain. We've come across this in either cystitis or, let me check right now, we've come across Yeah, we've come across it in cystitis. Cystitis was the other kind of renal condition where we had this suprapubic pain. Okay, now the ureter is going to have loin to groin pain. That's what it's known as. And this is because there's kind of like spasms of the ureter in an effort to push the foreign substance out. And due to that pain, the pain is kind of like it's not radiated, but it is kind of progressing because the ureter then covers that area, that length. Then you have renal pelvis. If it's stuck in the renal pelvis, this is just straight up flank pain. Okay. Now, what do we say next? What about the treatment? So, for the treatment of all of these stones, you kind of start off with lithotripsy. Okay, as I mentioned, when it comes to okay, well, okay, when it comes to your patient, you you need to treat what's the symptom that's right in front of you. And if that is acute excruciating pain, you want to then give diclofenac for the acute pain, okay? You want to give the diclofenac for the acute pain. These drugs you need to remember and be able to recall. Okay, and remember, if the size is less than 5 millimeters, you want to give fluids because it can help pass the stone out by itself. If it's more than 5 millimeters, but up to 2 centimeters, you're going to give lithotripsy, which are those waves that break down the stone. That's not invasive. More than 2 centimeters, yep, you have to go invasive because this is 20 millimeters is big. You have to do a percutaneous nephrolithotomy, okay? Now, there are medications that we can use. So in the case of the 5 mm to 2 centimeters, you can also use medications to help with the pain. By the way, if it's less than 5 millimeters, but there's no pain, then you kind of give the fluids. If it's more than 5 millimeters and there is pain or it's painful, so it doesn't have to be more than 5 millimeters lithotripsy. If it's painful, then you're going to give diclofenac for acute pain regardless, but then you're also giving these alpha blockers, and these alpha blockers such as tamsulosin is going to help relax the smooth muscle. Remember, calcium channel blockers also relax the smooth muscle. And the ones that relax the smooth muscle in calcium channel blockers are the ones that end in dipine, right? Remember that nifedipine is the most appropriate one here. And when the calcium channel blocker high yield drugs that you need to know are that nifedipine can be used to relax smooth muscle, but verapamil is cardio-selective. So verapamil is cardio-selective, as is diltiazem. Now, nifedipine, by the way, nifedipine can be used in subarachnoid hemorrhage, so it's cerebroselective. Verapamil is cardioselective, and nifedipine is cerebroselective. Nimodipine. Okay, nimodipine is cerebroselective. Sorry, nimodipine is cerebroselective, whereas nifedipine is the one that can be used for hypertension in pregnancy. So once again, nimodipine is the one that's cerebroselective and can be used in subarachnoid hemorrhage, and nifedipine is the one that can be used in hypertension in pregnancy. Okay. Amlodipine can be used, but not so much because it acts kind of on the peripheral vessels mainly. Now, just to recap, too many electrolytes, too many substances, you're going to get buildup of these stones. Too little water, and you don't have as much dilution of those substances, right? Your most appropriate investigation is non-contrast CT scan. You want to know the differences between radio-opaque and radiolucent stones and which ones are radio-opaque and which ones are radiolucent. You want to remember for the intermediate level, you want to remember Staghorn stones, and you want to also remember the approach. Now, the approach is very important clinically, but I'm still marking it as the intermediate level for people who are doing pathophysiology. Okay, the approach to the stones depends on their size, less than 5 mm fluids, more than 5 mm lithotripsy, and more than 2 centimeters percutaneous. Basic level of understanding requires you to know that pain and hematuria are the most common symptoms of renal calculi or of urinary calculi, and diclofenac for the acute pain. Lovely. Thank you so much for listening, and until next time.